Well, it sure is nice to see a lot of familiar faces here, and thank you very much for the invitation to come. So this talk is going to be a little bit of a change of pace because it's mostly going to be focusing on transplantation, a little bit about specific cystinosis issues in transplantation, but more or less transplantation as a whole. Because there's so many families here, people, and many of them will be looking at a transplant sometime in the future, I was asked to do sort of a whirlwind tour of everything you might want to know about transplantation, but we're afraid to ask. So, people in the audience will have various experience with transplantation. Some will have been through it already, they'll be living with a transplant, or children will have had a transplant. Others, it may be something in the future. So, I'm hoping to teach something to you at different levels, and some of these things I'm going to mention, you'll have known already, and so I apologize for wasting your time. Basically, we're going to look at the W's of transplantation: who, what, where, when, and why. Starting off with who. Who is eligible for a kidney transplant? Who can donate? And maybe, who should donate? Because it's got to be direct line of sight. Has to be direct line of sight. Okay, now I understand. So, for a little bit of perspective, I like to show this slide just to show the number of people who are at risk for needing a kidney transplant in pediatrics. So this is a summary of information from the Center for Disease Control. And in the US, there's about 10,000 kids living with end-stage renal disease, about 5,000 kids living with a transplant, so about 15,000 total. To put that in perspective, that's 3 times the number of kids that are living with HIV. But the number of kids living with cancer is about 10-fold as much. So that puts it in perspective for the size of the population and the problem in the United States. When we talk about chronic kidney disease, we talk about the staging of CKD, and Dr. Eddie's going to talk a bit about that tomorrow in her talk as well, about managing patients with kidney, with cystinosis. But we talk about the 5 stages of CKD. Stage 1 is when you know you've got chronic kidney damage, but the kidney function, as measured by the GFR, is normal. So in the pediatric world, there's a way to take the serum creatinine and then throw in the patient's height and do a calculation, and you come up with what's called the Schwartz GFR. Not related to the Schwartz, like may the Schwartz be with you or anything like that. It was a guy's name. So if you basically have normal kidney function, but you know there's something wrong with your kidneys, you're stage 1. A little bit of reduction in kidney function, stage 2. Moderate reduction, stage 3. Severe reduction, 15 to 29 GFR or percent. And then kidney failure, less than 15%. So the stages of kidney disease are used all the time in clinical practice, and so you can go back and ask your pediatric nephrologist, what stage is your child's disease? When you develop end-stage renal disease, or near end-stage renal disease, we believe that almost every child is a potential kidney transplant recipient when they get that far along. And so our philosophy is to try and actually avoid dialysis if possible and go right to kidney transplantation. This is a picture from the very first successful human kidney transplant. It was done in the late 1950s, and it was a situation where dialysis didn't exist. A young man had kidney failure and was dying, and he happened to have an identical twin brother. So the identical twins, one was ill, one was healthy. The healthy guy gave his kidney to his dying brother and saved his life. No immunosuppression. And the brother lived many more years, about 7 or 8 more years before he passed away because the disease that took his original kidneys came back. But this young man saved his brother's life for 7 or 8 years, which he was very grateful to do. Well, unfortunately, we don't all have twins, and so we use immunosuppression. So one of the points is that you have to take medications for immunosuppression after kidney transplant for the rest of your life. But we've become really successful at doing immunosuppression and doing kidney transplants. And because of that, people who are on dialysis want to get a kidney transplant. There's a problem. This is the waiting list for kidney transplants, and this is the number of kidney transplants that are done. As you can see, as we go up to 2008, the waiting list is almost 100,000 people waiting for kidney transplant. But the number of deceased donor kidney transplants has remained pretty much stable, a little bit less than 10,000. And the number of living donor kidney transplants has been coming up, but it's still less than 10,000. So there's lots of people who don't get transplanted. So because of that, the wait for donors is really important. So here, Zitz, what's up, Pierce? My rat needs a liver transplant. We're just waiting for donor organs to become available. Will it take a long time? It's up. Depends on the cat. It would be so easy if that were the case for us. In our organ distribution area, Arizona, California, Nevada, this is the wait time. If you're over the age of 18 and you're put on the list, and you're blood type O, you wait more than 8 years. B, more than 8 years. Type A, 6 to 7 years. Type AB, slightly less. So if you are put on the waiting list after your 18th birthday, this is your wait time. But, can't see. So the decision was that if you are at an organ transplant program and you get a deceased donor who's less than age 35, except for some certain situations, those kidneys will be offered to a child first. So the children get the best quality organs, as long as they've been on the list before their 18th birthday. So what that happened was when Share 35 came in around 2005, is this was the number of living deceased donor kidney transplants being done in children in the US, and this was the number of living donor kidneys. So on average, we were getting about 800 to 1,000 kids being added to the list every year. We started doing less living donors because these kids could get deceased donors. Seems like a good deal, right? Maybe not. Because although you could say you could get them transplanted from a deceased donor and then the parents or the siblings didn't have to donate, we paid a price. This is the outcomes as of 2010 reported by NAPROTICS, which is the North American Pediatric Renal Transplant Collaborative Studies. So if you have patients who get a living donor kidney transplant between 1996 and 2010, this is their outcomes. So at 7 years post-transplant, 80% still have a functioning kidney. In that same time period, if they got a deceased donor kidney transplant, we're down to about 67% still have their kidneys. There's a difference of 13%, so you lose 13% survival over that first 7 years. But what's more worrisome is there's also a mortality issue. We know kidney transplantation is a big surgery. We have to take major medications, and there are side effects, which we most of the time can manage really well. But there is a small mortality rate. So looking at all the kids transplanted in the US, at 7 years, the mortality rate, if you get a living donor, is about 95%. Survival rate is 95%. But you lose about 3 or 4 points of mortality if you get a deceased donor. So if you get a deceased donor kidney, there's a slightly higher mortality rate, and the kidneys don't last as long. So our philosophy at Stanford is whenever possible, we aim for a living donor, and if there's no living donors available, we'll go to deceased donors. This slide just shows it doesn't matter how old the child is. This is the age of first treatment, either dialysis or transplant. Infants, preschoolers, early school age, late school age, teenagers. If you're on dialysis, your mortality rate, your survival rate at 2 years is poorer. The best survival is always living donor transplant, and intermediate is deceased donor. So we really aim for a living donor if at all possible. So, who should donate? Obviously, we do a really thorough screen to make sure that you are healthy, or your relative is healthy, or the member of your church who wants to donate to your child is healthy. But we always try and go for a living donor if possible. What will my life be like after the transplant? What problems might happen? We know, you've read about transplantation, you know there are all sorts of issues, and I'm just going to talk about a few of them. One of the big issues is always side effects. And the drug that you hear about side effects most about is prednisone. And prednisone is about oodles of side effects. When I was in training, I was at UCLA, and one of my patients was Gary Coleman, the kid from Different Strokes. And the reason he looked the way he did was because he had gotten a lot of steroids. We have moved beyond this. I'll show you in a couple of slides. Infections. There's no doubt when you're on immunosuppressive drugs to protect you from rejecting your transplant, it's harder for you to fight infections. And so we teach the medical students about all sorts of weird diseases and viruses that can happen to people at various times after their transplant. But the key thing is a lot of these diseases we can now prevent. We have antibiotics to protect you during the first 6 months, which is your high-risk period. We're encouraging people to be vaccinated against certain things. And so we are licking most of these infections. But using multiple drugs, and especially in high doses, has side effects that are still problems. So this is a girl of Filipino descent, and she was placed on cyclosporin and prednisone after her transplant. And she developed the hairiness that we see on patients with steroids and cyclosporin. She developed gum overgrowth from the cyclosporin, and she developed warts, which was a sign that she was over-immune suppressed. More terrifying is cancer. We know that the same immune mechanisms that we have to suppress to treat rejection are used by the body to fight certain cancers. So there's a clear increase in the rates of certain kinds of cancers. But we're winning on that battle as well. This is a patient who developed a post-transplant lymphoproliferative disease, and these big white things in his brain was a metastatic tumor. We now know that that's from Epstein-Barr virus. We now put these patients on antibiotics to prevent Epstein-Barr virus the first year post-transplant. So this, which we used to see a lot, is becoming more and more rare. We have vaccines. You've heard of Gardasil, the HPV vaccine? Every patient who's looking at getting transplanted sometime in their life should get Gardasil before they're on dialysis, before they're transplanted. Because Gardasil protects you from HPV. And in the adult transplant population, they have a 3 or 4 or 5% higher rate of cancer of the cervix from HPV. If you get vaccinated before you're on dialysis and transplanted, you don't need to worry about that. So we are making clear strides in getting these patients to have optimal rehabilitation. What we figured out is, when I first started, everybody got the same drugs. It was like, you go to McDonald's, you get a Big Mac meal. Everybody got Inuran, everybody got prednisone, everybody got cyclosporin, everybody got O53. We've learned now that we tailor the immunosuppression. Some people need more, some people need much less. If you get it wrong, you get allograft rejection if there's not enough. If you get it right, you get these complications. But we're doing a much better job now at getting it right and ultimately causing good outcomes. So this is a little guy who got transplanted here. Immediately after the transplant, he's got Cushingoid side effects from steroids. His eyebrows are a little bit bushy. But as we backed up on the immune suppression, all of a sudden he starts growing, he gets skinny, he's living in California, so he's drinking a Diet Coke. And he's still doing very well 10 years later. This is wonderful rehabilitation. Anybody recognize who the big guy is, not the little guy? Alonzo Mourning. Alonzo Mourning. So Alonzo had a kidney transplant because he developed FSGS, and he was able to get his transplant and come back and play in the NBA. And there's another guy who also is in the NBA who that's been transplanted. Just forget his name. Anyway, so we know that we can get these people to play professional level sports. They can have great careers. They can go to college. They can have kids. And so we focus on getting the kid totally rehabilitated, and that's usually what's pretty successful. Now, one of our problem areas is the area of age 11 to 17. So this is the 5-year transplant survival by recipient age. And so the orange is deceased donors, and the yellow is living donors. And see this dip here and there? So why do you think we have a dip in that age group?
Non-compliance with meds.
This is my teenagers. I don't know if you can see that very well, but this is my experience of what I think when I come home and I chat with my teenagers. Non-compliance. There's no doubt about it that non-compliant teenagers are the problem. We know that if you look at the number of drugs that you're prescribed, the blue line is the number of, sorry, the red line is the number of drugs you're prescribed. The blue line is the number of pills you actually take. The more pills we prescribe, the poorer the compliance. And in people who are getting cystagon and all those other things, you know that compliance is difficult. Well, why don't we just say, since teenagers are so non-compliant, leave them on dialysis. Wait till they get smart, get their frontal lobes grown in, and then transplant. Some of the teenagers might not be until they're 25 or 28. Unfortunately, if you leave a teenager on dialysis, their mortality rates are higher than if you transplant them. Teenagers are impulsive. They get in a fight with their girlfriend, they go to the 7-Eleven, they had a bean burrito, chocolate bar, and a soda, and they can die from heart failure from a high potassium. So we transplant these kids anyway, and we do what we can to get them through. And most of these patients get very well rehabilitated. Most of these patients that you can't tell in my waiting room who's the transplanted patient and who's the healthy sibling. Most of these patients have a job. Most of these patients are age appropriate in school and in college. So we're really, really happy. It's not perfect, but it's really good for most of the patients. Okay, next W. Where do you put it? This one's easy. This is a donor kidney that's been removed from a living donor, from a deceased donor. There's the artery, there's the vein, and then there's the ureter. When we sew the kidney into a recipient, we don't put them where the original kidneys are. The original kidneys are way in the back and hard to get to. We actually put the kidney down here, and we hook up the kidney close to the vessels here, to the legs, and close to the bladder. So if you zoom in a little bit on this picture, this is an example. We've got the kidney basically right here, right cradled by the hip. And the ureter is very close to the bladder, so that's an easy operation, and the vessels are hooked up here. And so you can feel the transplanted kidney afterwards. And so the children will tell you if the kidney is sore, and we can easily biopsy and examine the kidney. So it's not way back here. We often leave the original kidneys in. People always ask that question. It kind of depends on how much urine the person's making. If they're making tons of urine, we may take one of the kidneys out at the time of transplant. Okay. When? This is always an interesting question. When can I expect it to happen? When might I need another transplant? The time your child may need a transplant can often be predicted. And so we'll draw these graphs. So this is the same patient, and this is taking the serum creatinine and plotting it on this graph, or reciprocal creatinine graph. Or remember I talked about the Schwartz GFR early on. You can plot the GFR, and in most people who are slowly losing their kidney function, those dots are more or less on a straight line. And so, like in this patient here, we predicted that they'd be at about 10% kidney function in time for transplant. This was September 2012. So we can often give a kind of an idea when that person might need the transplant. Different children lose their kidney function at different rates, and so the slope is different in these selected patients. But as you can see, the lines are relatively straight, so it can give the family some kind of an idea to predict. Now, when patients are losing their kidney function, sometimes the lines change. Oh, sorry, step back. I wanted to point out something. The creatinine, when the creatinine starts going up, when your child starts to lose their kidney function, the rate that the creatinine changes speeds up. And that's something which is very shocking to a lot of parents. So if you look at this chart, there's the serum creatinine of 1, and there's the serum creatinine of 2. There's quite a bit of space there. So it takes a long time for the creatinine to go, say, from 0.8 to 1.5 or 1 to 2. But then going from 2 to 3, oops, less space. 3 to 4, less space. 4 to 5, kidney transplant territory, much less space. People always say, everything was doing so well, his creatinine went really slowly, then all of a sudden, the last, okay, there we are. So the other thing is, you can change the slope sometimes and be fooled. So this is the teenager who refused to go on dialysis. So there was the serum creatinine as it was deteriorating. And around here, January of last year, when his kidney function was about 10–12%, he said, this is time to go on dialysis. He was an A student at his school. He was swimming varsity swim team. He did not want to go get transplanted or go dialysis. He simply refused, and his parents couldn't convince him. So over the next year, he would come into clinic and say, look, my kidney function is stable. And indeed, his creatinine stopped going up. But what was happening was his nutrition became poor. He was eating less. After 3 months on dialysis, he took a subject SAT exam which he had failed. Without doing much studying, and he got a B+. So he went from failing to a B+ by going on dialysis. But we really had to twist his arm to get him on dialysis. But what it shows here is that the serum creatinine didn't change. But what was happening was as he became malnourished and he lost the muscle that makes creatinine, That was fooling us all. Well, it was fooling him more than anybody else. So anyway, we aim for a kidney transplant preemptively before you're on dialysis most of the time. Okay. When might I need another transplant? You know, you can't make a really strong recommendation here, but a general rule of thumb, deceased donors last around 10 years. There's lots of variability. The better the donor, the more compliant the patient, the healthier the patient, the longer it lasts. But also, there's a certain amount of luck there. But living donors, on average, last around 20 years. A substantial difference. Oh, and related or not doesn't seem to matter. We initially thought the living donor advantage was because there was a blood connection, and it turns out to not be relevant. We have done lots of transplants from spouses, husband to wife to husband, and they do just as well. So what we've recognized is the fact it's a living donor. So we transplant people where someone in the family can't donate, but they've got someone from work, or someone from the church, or someone from the community who knows them and has been a good friend. Good. We have one slide. We have one slide here, outcomes specific to cystinosis. So this comes from the NAPRTICs, the North American Pediatric Renal Transplant Cooperative Trials, and this was one little graph in their 2010 book. And what they're talking about is the cystinosis outcomes. So this is actual outcomes in the U.S. A total of 221 transplants over the period of time from 1987 to 2010. So patient survival better than 95% at 5 years. Graft survival a bit better than 80% at 5 years. That's all comers. But notice patients that were transplanted before 96, 3-year graft survival 70%. This is deceased donors. Patients that were transplanted after 97, marked improvement in graft survival. So we're learning really a lot. So these are excellent outcomes, and just to put a comparison, this is another metabolic disease which happened to be on the same slide, oxalosis. There's the patient survival, there's the graft survival. So the cystinotic patients do really well. Why not get it over with? Why wait? A transplant is so bloody good. You know, we take out his kidneys, he'll be peeing at night all the time. You know, forget this phosphate, forget this bicarbonate, let's just go to transplant. Well, after my talk and discussing things like the risk of infections and things like that, hopefully you understand that the kidneys that you're born with, even though they have cystinosis, are still better than a transplanted kidney, if at all possible. If you look at the outcomes from the 1960s to 2000, this was the rejection rates, and this was the graft survival rate. So every year we've been doing better and better. And that's because of the use of new medications and our understanding of how to use the new medications. This is a cartoon of an immune cell and its interaction with a potential kidney transplant. And all these white boxes are drugs which we either use now, or used to use, or use now, maybe using in the future. So there's all sorts of things we're learning. In addition to new medications, we're also learning how to use older medications. And this now is information we got from Stanford. A decade ago, Stanford really was pushing using steroid-free immunosuppression. And what this is an example of the growth of children aged less than 6 who got transplanted. And if they were on the steroids, they stayed 2 standard deviations below the mean, so sort of 5th percentile or less. They didn't grow that much when they were on steroids. The steroid-free patients actually caught up growth, so they do much better. Kids over the age of 5 to 15 also, if they're steroid-free, they have catch-up growth, no catch-up growth if they were steroid-based. So we're learning how to use immunosuppression without steroids. And look at the differences. Cushingoid facies, which is the big swollen face that kids on steroids get, 100% steroid-based, 0 steroid-free. Acne went from 76 to 3%. But look here, obesity. Mean body mass index, 22, which is normal. Steroid-based, 31. So we've made a huge inroad on growth and obesity by being steroid-free. And what's really gratifying is how well steroid-free immunosuppression is being accepted in the US. Next slide. Also, the prednisone doses, if you look at the number of months post-transplant, and the dose based on the child's body weight, it's also been coming down. So even if people are on prednisone, the doses we're using are better. Next slide. So we're looking at any possible research to try to improve outcomes. I keep telling the surgeons, this is what they should do. They don't listen to me, I don't know why. Next slide. So when the immune system sees a kidney transplant, the immune system sees that kidney and then it makes an important decision. It can decide to reject the kidney, or with certain drug therapy, we might be able to trick the immune system to accept the kidney. So this decision will have long-standing profound effects, kind of like our children making decisions. Next slide. This is in Northern California. There are 2 towns close together. Next slide. So this is a drug which is being used in a couple of centers, including Wisconsin, and it may be having some benefit at developing the idea of tolerance. The idea being that you can give the drug early on, and the immune system will be convinced that you can accept the kidney afterwards. So we have a number of drugs like that in the pipeline. We also have a drug which has made it through the first round of clinical trials that you can give once a month. So for all those non-compliant teenagers, they can come in, get a quick shot, and be safe for a month. So there's a lot of cool things happening. Next slide. And you thought animal research was just to help humans. So I just want to point out that all of the things that I've talked about, the clinical work that we're doing, a lot of it comes from basic science research in the lab that you've been seeing, and basic science research with animals. And so when you're looking at out there raising funds, if people start talking to you about animal research, this is really expensive to do research on animals, but we really need it because the human body is just too complex. We don't understand anywhere near what we need to understand. And the only way to do it at certain times is with animal testing. So I hope that you'll be champions for that if that ever comes up. Next slide. I think we're done. Right. Okay, thank you very much. I'm sorry for the technical stuff.
Could you clarify blood type in relation to organ transplant? Our son has a rare blood type, AB. As far as who could donate to him, we've heard universal donor, or just, I don't know, does that complicate things because of his blood type?
The blood type thing can be quite complicated. And so before I talk about your son's case, one of the things that's really coming up is what's called donor chains. Say, I have a child who has kidney failure, and I want to donate to him, but my blood type doesn't match. And you've got a child with kidney failure, and you can't donate because your blood group doesn't match. We can develop a donor chain. And there's software and interagency arrangements and inter-hospital arrangements that are working on this. So you and I go to the OR at the same time. My kidney gets popped out, yours gets popped out. My kidney goes into your kidney goes into my kid. Everybody's happy, and we get 2 successful living donors out of it. That's a donor chain. I think they've had donor chains that fit with 17 patients that link together. So there's actual software that's used by our organization trying to work on them. So that's the first thing. So blood group doesn't necessarily mean you can't get a living donor transplant. So if you are a child who is O, you don't have A or B. So if you get a kidney from an A or B, you are likely to reject that kidney very quickly. On the other hand, your child is AB, so you can give any kidney you want, A, B, or O. There's also some ways that we can cross the A and B, the A barrier, because some people who are A are actually A2s. So you can give them, it gets really complicated. Talk to your doctor.
What is it like for the donor? What results do they have?
They, we have this oath in medicine that we're supposed to really live by, and that's first, do no harm. The donor workup is intense, with a lot of real care to how healthy that donor is, and is there any potential risk that donor might be at increased risk of kidney failure themselves and need both their kidneys. So there's a tiny bit of evidence that if you donate a kidney as a young person, you might have a slightly higher rate of high blood pressure. But that's all the detriment we find. In fact, some insurance companies will give you lower rates if you've been a donor because you've been worked up the wazoo. They know you don't have cancer. They know you're not obese. They know you're not diabetic. So you actually have a better chance for, a lower chance for dying, and so you're a better risk for the insurance company. You can be in the military. So in general, statistically speaking, being a donor isn't a bad thing for you. It's still an imperfect process. There's about a 1 in 30,000 chance of anybody dying under anesthesia. So when you go into that, you know there's a tiny risk every time you put to sleep. And so there's a chance for surgical complications. Most of the donors I deal with, back to work at 6 weeks to 3 months. If they're doing heavy manual lifting, it takes longer. If they're smokers, we'll tell them you need to quit smoking because we don't want to take the risk with you. If there's any sign of early diabetes, we just don't want to take that risk, so we don't take it. So we really try and follow that guideline first and no harm.
Bonnie?
Yes, my question is, I've heard, I don't know if it's true or not, but that it's harder to get a good addition match on for a kidney transplant if the patient is getting an awful lot of blood transfusions?
Mm-hmm. Yes. There's something which I didn't discuss at all in this meeting, and it's called HLAsensitization. Our tissue type is something called HLA, and it's quite a complicated system. But what can happen is if your body sees other people's tissue, you can develop an allergic response, and that'll prevent you from being transplanted easily. And you get exposed to other people's tissues by blood transfusions, by being pregnant, or by having had a previous organ transplant. And if you get a lot of exposure, and if you're a bit unlucky, you may develop HLA sensitization that makes you much harder to get a kidney transplant. Again, we have some technology and we have some therapies that we're using to reduce sensitization. We have patients who have come to us from other centers, and now many centers throughout the US are doing this, where we have a process where we can desensitize many patients. So even though they were told 5 years ago they could never be transplanted, we can transplant many of those now. And the donor chain is also really helpful because there are patients that are sensitized to the living donor, but we can put them into a donor chain and maybe find somebody, you know, we're in Stanford, we can find somebody in Albuquerque who can get into a donor chain and we can get that person transplanted. So we do have options, but it's harder. So we really try and avoid blood transfusions if possible.
What?
Could you use the mic again?
Sorry.
Better.
Okay.
I had a question about nephrectomy. I know there's been a few cystinosis patients who lost their donated kidneys because their old kidneys are still creating so much urine and dehydrating the kidneys. How do you decide whether or not to have a nephrectomy, and what if you're working with a nephrologist who's never worked with cystinosis patients, and how do you make that decision?
When a person is approaching a transplant, we will do a 24-hour urine to collect the urine for 24 hours to determine how much protein you're losing, because damaged kidneys will leak a lot of protein, and how much fluid there is. And because people with cystinosis will pee a large amount, if we transplant them early and electively, without waiting for them to go on dialysis, those native kidneys will make a lot of urine, which is water. They're not cleaning the blood well enough, but they are peeing out water. And so then when we put in a new kidney transplant, we want that kidney to get the perfusion, but the old kidneys are still dumping the water, and so the patient is more likely to clot their kidney. In that situation, what we'll do is, before we go into the transplant, we'll plan to take out at least one of the kidneys at the time of the transplant. So, in fact, we have a person where we're going to do exactly that. We go in through the same incision. Our surgeons really try and make a nice little bikini incision for the girls and for the guys, doesn't matter. But you can open it up and you can work up to get at least the right kidney out. So we can remove that kidney at the time of transplant and reduce the risk that the child will get dehydrated and will lose that transplant. And so hopefully we won't be seeing that in the future, but that's a well-known, recognized complication. So that's, in our center, we would just quickly advocate to taking out one of those kidneys.
So is it based on volume, or is it based on the amount of protein you're spilling?
Both. If you're leaking a lot of protein, that's a reason to even consider doing the kidney nephrectomy earlier. We have some patients where they leak a huge amount of protein, and that puts them at risk for malnutrition and clotting of the transplant. And so in those patients, what we may do is take the kidneys out, put them on dialysis for 6 weeks to allow them to build up their own protein levels, and then transplant them at that point. In most cystinosis patients, they're not losing that much protein, so it's just a volume issue. So if you're peeing less than 1 liter a day, it's not an issue. But if you're peeing 4 liters a day, that's a substantial issue.
Sue?
I am hoping to see potential brain and obviously I'm overweight somewhat, so before they'll even test me, I have to lose 20 pounds. Why can't I be tested ahead of time to even determine if I would be appropriate damage?
Well, I don't know. Here's a guess though. The blood tests cost about $1,500. So if they do the test and you can't get the weight off, the transplant program has lost $1,500. So maybe it might be that. If you show that you are motivated enough to lose the weight, then they'll do the test. And if you can't donate, you've still lost the weight, so you're ahead. It's a possibility. We can do some simple tests relatively quickly. But I do think that being overweight puts a risk for you, and also makes the surgery more complicated because it's harder to get the organs out satisfactorily.
The deceased organ has a less mortality.
Why they do poorly?
Yeah.
Well, does your mother know everything about your life? No way. No way. So we get these people who are 20-year-olds and their families say, oh, he's great, he's an athlete, he's fine. And it turns out that they actually were smoking drugs or drank a lot of alcohol and had lots of hardening of the arteries. So when we get a donor, we don't know everything about them. Also, when a deceased donor happens, what you understand is the brain has died, but their organs are kept going on life support. In the act of brain death, the body develops inflammation, and that makes the kidney inflamed. And so when that kidney goes into your new recipient, the immune system notices it a lot more. With a living donor, the kidney is working away, it's perfectly fine and very healthy, and then we put the patient to sleep, and within a couple seconds we've gotten the kidney out and it's in the ice bucket, it doesn't know what hit it. And so when we put the kidney into the new recipient, it's a very happy kidney, and the recipient's immune system is very comfortable with that. But with the deceased donor, that kidney is injured, and the immune system has developed mechanisms to recognize tissue injury. And when there's the tissue injury signal, is the thing that activates the immune system. So all of a sudden, the recipient's immune system is very homed in on that kidney. So, in summary, it's the injured kidney to start with, and you don't know exactly how healthy that kidney is. So those are some of the reasons why the deceased donors in general do poorly. Okay?
Okay, we're going to let you go here.